Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Well, hello and welcome to the show. I'm Dr. Adam Stryker, editor and host of Central Line. Today we're going to talk about a little bit of a prickly subject, depositions. Now, to shed light on the topic, I'm joined by Dr. Ashley Eltorai and Dr. Joseph Answine. Before we start, a bit of a quick disclaimer for our listeners. Nothing we'll say here today constitutes legal advice, and you should, of course, consult your own counsel about the topics we're going to cover today. But let's get into the discussion and get started. First, I'd like to invite you both to tell our listeners a little bit about your clinical roles and your interest in the legal side of medicine, and welcome you both to the show. Thank you.
Well, thank you, Dr. Stryker. Very excited to be here. I'm Dr. Ashley Eltorai. I am an assistant clinical professor at the University of Connecticut School of Medicine, and I am also currently earning my Juris Doctor degree at the University of Connecticut School of Law. So I certainly have an extensive interest in the legal side of medicine. I have engaged in a fair bit of medical legal consulting. I have given a talk for continuing legal education to a group of trial attorneys and have also undertaken a good bit of medical legal research projects. So I have quite the interest, I would say.
And I'm Joe Answine. I am a teaching faculty and professor at Penn State University Hospital in Hershey, Pennsylvania, in the Department of Anesthesiology and Perioperative Medicine. I'm proudly on the board and the executive committee of the Pennsylvania Society of Anesthesiologists, and I'm on the board of the American Society of Anesthesiologists as the alternate director for Pennsylvania. And my interest in this topic stems from being a defense expert for the last couple of decades. And I've learned a lot. I think that I've been able to pass on a lot of wisdom by being in that position for many, many years.
Well, wonderful. This is a topic I'm quite interested in. It's not something we have really covered on Central Line, but it's a topic that I know comes up quite a bit amongst our colleagues on a not too infrequent basis, just in discussion. Let's start out, Dr. Eltorai, if you don't mind, telling our listeners about potential risks we should be particularly mindful of in general.
So your question here, as I understand it, is what kinds of clinical practices or scenarios increase our legal risk, meaning our risk of being sued for medical malpractice? Oftentimes, I think doctors denounce the idea of practicing defensive medicine and doing just this, focusing upon legal risk in guiding their practice. I think it's a term that typically has a very negative connotation, defensive medicine. But there's a really key concept that I found. When you're practicing, quote, defensive medicine, you're often actually also just practicing good medicine. When you're practicing in a way where you're giving careful thought to your clinical decisions, in a way that's evidence-based, in accordance with ASA guidelines and standards, you're documenting your care honestly and thoroughly. At that point, you're not just looking at mitigating medical legal risk. You're delivering high quality patient care. So in that way, I think that patient safety and medical legal risk reduction are often quite aligned. So be a good doctor. First and foremost, provide the kind of care that shouldn't need defending. And then what if it does? Well, then you want the record of that care to speak for itself via thoughtful and high quality documentation that's done in real time. But number one, just be a good doctor. Be who you already are.
I think anybody listening is certainly on the same page about wanting to practice good medicine and evidence-based medicine to the best of their ability. Oftentimes, we're all presented with situations where there's no cut and dry, clear answer. And we're left, as usual, as is the case with physicians, to try to make the best decision possible amidst the circumstances. I get the feeling that a lot of colleagues will then try to go in more of that defensive mode by maybe not doing what they really think is probably in the best interest for fear that it is going to be misinterpreted, or even with documentation, quote unquote, a good lawyer is going to be able to pick that apart in spite of what their intent was, or they're not legal experts. And so they're worried that maybe they're getting into a situation that they perhaps don't understand the right documentation and whatnot, and the legal ramifications. Then they just say, you know what, I'm going to just practice the most conservatively I can, because even though I'd like to do this other thing for the best of the patient, I am worried about what's going to happen. So I just want to have you follow up with your thoughts on those situations where they're not so cut and dry.
That is an excellent question and a concern that certainly is shared by many. So if you are thinking beyond the realm of just practicing good medicine, which you're already engaging in doing every day, and you are really wondering and concerned with legal standards for your care and exactly the points that you just raised, maybe think about the legal definition of standard of care. This is the care that a reasonably prudent doctor in similar circumstances to the one in which you find yourself would provide. So thinking about the people around you, they may have had one of several responses to very similar clinical scenarios, something that you've all discussed casually in the workroom when a certain topic came up. But you'd look around at those individuals and think, that would not have been the exact decision that I would have made, but that's reasonable. There's no doubt when I listen to that person's reasoning and I consider the data that they used in making that decision, that was a reasonable choice and they were acting as a reasonable physician. So thinking about what is reasonable in delivering the standard of care. And there are multiple ways to do that. And then as you alluded to in documentation, yes, perhaps folks have not sat on the other end and explored what is really scrutinized and considered in medical documentation by attorneys during medical malpractice litigation. However, what you know how to do very well is complete medical documentation in real time according to a complex, sophisticated clinical decision-making process that you undertake every day, that you've articulated orally on oral board examinations, that you've become an expert in doing. So, for example, you're deciding between an LMA or rapid sequence intubation for a case that requires general anesthesia. So if you sit down before induction, before any of the clinical events occur, and you just complete your preoperative assessment in Epic or your electronic medical record software, you do that in real time. You write down the pertinent positives and negatives, you're clicking the boxes, you're reviewing all of the available information that you see in front of you on the screen one more time, just ensuring that it supports your anesthetic plan. And then maybe something comes up as you're doing so and you think, oh, well, there's this one piece. And when I look at that on the screen, it doesn't seem to fit or support the decision that I'm making for the choice of airway here. But really, when you weigh this versus the other factors, I still wouldn't make a different decision. So then mention it. Just go ahead and mention that in your documentation. And essentially, you're being thorough, you're being thoughtful, and articulating why your chosen approach is what you believe with the information you have in front of you to be the safest and most appropriate for your patient. So then you're practicing both good medical legal documentation and, again, good medicine.
Okay, well, let's get into the specifics of the malpractice claim itself. When we talk about medical malpractice or a claim, what exactly are we discussing? What are the elements of that?
Medical malpractice claims have what we call the 4 Ds. Those are duty, deviation, damages, and direct cause. So we'll just briefly touch on each. Duty means that there was a doctor-patient relationship, that you as the doctor had a duty to this plaintiff patient. Deviation means deviation from the accepted standard of care. That means that your conduct and your choices in treating this patient fell below what a reasonable doctor would be expected to do under similar circumstances. This is where the role of a medical expert witness comes in to testify what would be a reasonable doctor's course of action. And did it fall within reasonable or did it fall below standard of care? Then damages, the third D. That means that the plaintiff suffered actual harm, losses. And then the fourth D, which is direct cause. There are two layers of causation that you need to satisfy in order to bring a successful medical malpractice claim. The first is actual cause. This is the but-for test. So this means that you're asking the question, but for this doctor's actions, would this injury have occurred? And if you say no, then you've satisfied the actual cause, but then need to move on to the proximate cause part, which is also called foreseeability. And there you ask the question, was it reasonably foreseeable that this doctor's actions would have caused the damages that this plaintiff patient suffered? So this then eliminates from legal responsibility chance events that should in no way be connected to alleged negligence on the part of the doctor. And we should note that the plaintiff is the party who bears the burden of proving the four of these elements. And the plaintiff needs to do so according to a standard called preponderance of the evidence, meaning it was more likely than not, a greater than 50% chance, that the doctor caused the damages that the plaintiff suffered.
Okay, Dr. Answine, I'd like to get you in here a little bit. I'm wondering if you don't mind sharing a few things clinicians should consider when preparing themselves for a deposition or when a claim has been made and they have to engage.
Well, first thing you're going to know during this discussion is Ashley and I know each other. And what makes it fun to work with each other talking about these issues is we come at things from different angles and in different ways. The one thing Ashley and I agree upon is you could do everything right, but good doctors get sued. And you could do your notes correctly. You could take care of patients in the best way possible, but it can happen to good doctors because remember, you have a bad outcome and then a plaintiff's attorney will have that outcome and develop a thought process as to why it occurred and why negligence occurred. The most important thing when preparing for a deposition, you're that good doctor who's being sued and now you're coming to your deposition. This is going to sound weird, but you prepare for a deposition much like you prepare for an oral board exam. You have to study. You have to know the records. Whenever you are sued, there is a list of points or a list of areas where the plaintiff's attorneys feel that you've been negligent. And in the formal complaint, they will list every one of them. You need to go through each of those complaints, and you need to be able to defend yourself as to why those complaints are not valid. And you also have to make sure that when you defend yourself for each of those complaints, they are supported by those medical records. So that's number two. You need to know the records very well. When they ask you during your deposition, have you looked at anything prior to coming to the deposition? You're going to say, I looked at the medical records. Well, what they don't know is that you really studied the records. You know those records inside and out. You know that every point, every page, what went on, what you described, what you charted, and so on. So knowing those records, knowing the complaints against you, and being prepared to answer those complaints and tell your story of why there was no negligence involved, and then show that the medical records do support that is very, very important. The other thing you want to do is, if other depositions and other information has become available about this case before your deposition, you want to go through those as well. You want to know how other individuals involved with the care answered the questions, and you want to make sure that you are comfortable with what they said, because I promise you some areas of other individuals' depositions will come up during yours. So The key is preparation, preparation, preparation. Almost you want to go into the deposition knowing the questions that are going to be asked of you before they are asked. So look at this in a very, very similar way as when you went in to tackle your oral board exams. They're different situations, but that much preparation is absolutely needed when you walk into a deposition. You have an individual in front of you that is trying to prove that the claims made against you are absolutely true. You need to be able to explain during that deposition, because it's just like being in a courtroom. Explain during that deposition why those complaints are absolutely not valid, not true, and these are the records. This is how I support my answers.
What is the role of the attorney in the prep phase, in studying and preparing? I imagine that they have to play a key role in sort of guiding what you should be prepared for and how to prepare.
Your lawyer is very important. Your relationship with your lawyer has to be very close, because even though you know what you did was right, even though you know the records, your lawyer is going to help you understand how things are going to be phrased, how the plaintiff's attorneys are going to, in some ways, come at you with the questions, and how to answer the questions not only the most appropriately, but in a way that anyone who reads the deposition, anyone who's in the courtroom, can understand what you're saying, and you need to present it in a very believable way. So your lawyer is so important in guiding you through the part of the process that you know nothing about. You're a physician. This is a world that you are not familiar with. Your lawyer, most importantly, is that person that is going to guide you through the minefield so you can avoid the mines, the traps. And not that anyone's out there to deceive you, but there are ways that they can confuse you. There are ways that they could make you answer questions not in the fullest way, in the most appropriate way you want to answer to prove that you weren't negligent. So your lawyer is your partner. Your lawyer is going to provide all that information that you as a physician do not know or understand. So become very good friends with your lawyer. And most importantly, insist. If your lawyer doesn't insist to sit with your lawyer and go over the case, go over potential questions, go over your deposition, go over the parts of the chart that really are the most important when it comes to the claims against you. Let's be honest, no matter how smart you are as a physician, you really do not know this world. Now, you have people like Ashley that are studying law, and that's fantastic. But the majority of us, it's a very, very foreign situation. It's like going to a country and not understanding the language. Your lawyer knows that language. He's going to be your interpreter.
Well, Dr. Eltorai, do you mind talking a little bit about how the medical record is used in collecting evidence for a malpractice case?
Certainly. So the plaintiff will obtain full copies of the medical record and will look at timestamps. When was each piece of documentation entered and then edited relative to when case events occurred? In the example of making the decision for rapid sequence induction and intubation versus LMA, did you, because you were very busy, you were running multiple rooms, enter information regarding the patient specifically denying any GERD symptoms, any nausea or vomiting? Did you enter that information after the patient had already gone to sleep? That's important. It's important to the attorneys who are going back and examining this after, unfortunately, the patient suffered an adverse event. In real time, you were not thinking about that. You were focused upon providing efficient and quality care to your patients. But later on, it will now be a timestamp that for whatever reason, whether it was the reason that you know to be true, or because you realized that the patient had aspirated with LMA placement, and then might be the theory presented by the plaintiff's attorney, you decided to go back and make the pre-op look particularly favorable for the course of action that you chose, meaning the LMA. So those are two competing theories. Those two competing theories don't exist if you signed your patient's preoperative evaluation in real time before they went to sleep. Inconsistencies will be highlighted. Again, we are busy. In your electronic medical record software, we'll use Epic as an example here, you are very accustomed to completing templates, to clicking boxes that are in certain locations on the screen, and most patients fit certain boxes. For example, the assess portion of the intraoperative anesthesia record in Epic. You click assess, you choose the patient's heart rhythm. NSR is going to be the rhythm choice for most patients statistically. So you may quickly click through these boxes in the middle of a busy case and click NSR when in reality, this patient was in atrial fibrillation the whole case. And you knew that, but it's out of habit clicking a box in a location. Other examples just come from this ongoing, very real theme that we are busy doctors and that what is first and foremost in our minds is providing good clinical care, which never feels like a concept that should be punished. An example I'm thinking of is when the blood pressure dramatically bottoms out after induction and you're busy treating it. So you chart phenylephrine boluses, maybe you even escalated to vasopressin, and you chart all of those things 4 or 5 minutes later. So now, did you delay recognizing this blood pressure and treating it for 4 or 5 minutes? Absolutely not. You just didn't enter those drugs until the 4 or 5 minutes later when the blood pressure had stabilized because you put your attention and focus where they should be first. But now, while this anesthesia record is open during the case, you have every opportunity to look back at the times of the drug administration as they relate to the vital signs you're seeing in Epic. And if you say, look, by the time I clicked on phenylephrine, that was a solid number of minutes later, then change it to the actual time that you administered the drug. Another example of the importance of this, tying it back to the idea of simply being a good doctor. Did you have concern potentially for aspiration during induction of a patient and you took all the appropriate precautions and you were so relieved because upon performing laryngoscopy, you didn't see any gastric contents in the vallecula? You're so pleased for the patient. But do you document that? Are you going to click on the airway button and write MAC 3, grade 1 view, RSI, mask ventilation not attempted? Do you actually add in the comment section, no gastric contents visualized in the vallecula upon laryngoscopy? Maybe you should consider that in real time. Let's say that this patient post-anesthetic becomes hypoxemic and the ICU doctors are placing aspiration in the patient's differential for the hypoxemia. It would have been very helpful for those doctors, same day, to know that there were no gross signs of aspiration during anesthetic induction. They will then be more inclined to more strongly consider other reasons for hypoxemia during their workup of that patient. That is good medicine. That is helping your colleagues. That is being a good doctor. And also performing good documentation from a medical legal standpoint. So often they really do go hand in hand.
Then there is different threshold of tolerability for going back and documenting and cleaning up the record, if you will, for pre-op versus intra-op. We obviously understand the necessity of focusing all your attention on the patient at the time and then going back later and making sure the documentation is accurate.
The time stamping and the way that the entity is viewed as a whole for a preoperative assessment versus intraoperative documentation and charting will be different, simply because you cannot close the intraoperative anesthetic record, finalize that, sign that off until the anesthetic actually finishes. So the way in which you're shaping that record, whether it's happening at the moment that the blood pressure crashes, or more appropriately, you're focusing your attention upon the patient, then charting once stabilized, we're still talking about within that anesthetic. And we're talking about making these documentation points as close in real time as possible that makes sense for when you're able to devote the attention to the record keeping. But a preoperative assessment is a note that is signed and can be finalized, and we all know doesn't need to be looked at again, even as the anesthetic itself is still in progress.
Okay, so the general advice is to make sure you're signing the preoperative note in Epic before the patient goes to the operating room, because I know you can do it after the fact. Like, you can see the patient, assess them, and then you have some other issue if you're supervising multiple rooms.
Yes.
You go attend to that, and you're like, all right, just go back. I'll fill this out when I can here in a few minutes. But you're saying don't do that.
Best practice is to complete it in real time before any clinical events unfold.
Okay. Because that would be scrutinized if it came to that.
Absolutely, that would be closely examined.
So as best you can, try to complete that as much as possible.
Correct. And the intraoperative record too, you're closing the chart as close to the completion of the anesthetic as possible.
Sure, certainly. Okay. All right. Well, Dr. Answine, you've served as expert witness for defense in many, many cases. What have you learned from that role? And are there some key takeaways for anesthesiologists?
Well, there are. The most important thing is that no matter how well you chart, no matter how hard you try to chart perfectly, you are not. You know, the good news is, and I've said this on the stand, is, people don't necessarily die from bad charting. They die from bad care. So I concentrate on the patient, and the charting comes secondarily. No matter how good you are, whenever you get into these situations, there are going to be lapses in your chart. Just be able to explain why there are lapses, why there's a delay, why things don't line up perfectly, because the chart is not going to make or break you. It's you proving to the jury that you provided the best possible care. Speak in their language, make sure they understand, look at the jury and say, this is what I did. I was thinking about the patient, and this is why it's right. So now, interestingly, whenever you're in the courtroom, so when I've testified in the courtroom as an expert, all those things that you see on television, the courtrooms, law and order, all those things, I will tell you this, being in the courtroom is very much like that. You have a jury sitting in the stand, you have lawyers on both sides in suits and ties, and you're in a suit and tie. And I really believe as a defendant or an expert, the cross-examination by the plaintiff's attorney is what makes or breaks the case. Whenever you initially sit up there and your lawyer is talking to you and you're going over the case, he's throwing you softballs. He's leading you to answer the questions in the best way possible to prove that you committed no negligence. When the plaintiff's attorney gets his turn or her turn, they are not going to be like that. This is when the fastballs come out. This is when you hit 105 miles per hour straight down the middle. So the most important thing you can do is answer the question as completely and as fully as possible addressing the jury. So the plaintiff's attorney may say, yes or no, doctor, did you or did you not do this? What I have done in the past is I say, first of all, I will answer the question, but please let me explain my answer in this way. I can give the jury the most complete and most appropriate and the most truthful answer. So no matter how the plaintiff's attorney wants you to answer it, you answer it the way that is truthful, give the full answer, and if it's more than yes or no, answer it more than yes or no. Answer it as completely and as appropriately and as honestly as you wanted to answer it, and make sure the jury hears everything that you want them to hear, regardless of what the plaintiff's attorney wants you to do or say. So that's another important thing. When you get in the courthouse, when you're in that courtroom, take notes, listen to everybody that is talking around you, and make sure when it's your turn to speak, there is nothing left to be said. If there are things you want the jury to know, make sure the jury absolutely knows it. So whether you're a defendant or a defense expert, when you get on the stand and it's time for cross-examination, that's when you're going to win the case for yourself or the people that you are helping, the defense attorney, the defendants in the case. Get your answer out. Make sure nothing is left on the table when you are done.
Okay. Well, before we wrap up, for both of you, what don't clinicians understand about the legal process generally, or are there any myths or points that you would like to clarify or elaborate on for us physicians that are just listening about the whole process?
I certainly would underscore that, of course, having medical malpractice litigation proceeding against you would be a tremendously stressful event, and you want self-care. You want to seek appropriate supportive resources. That I would believe to be undisputed. However, I believe that there is a common misconception amongst non-attorneys regarding the discoverability of clinical notes, not clinical notes of the patient plaintiff, but clinical notes of the defendant, meaning the doctor in a medical malpractice suit. There is a misconception that because something is personal or private or even protected health information, that it would automatically not be fair game for the other side in medical malpractice litigation. That is not necessarily true. Take the example of seeking mental health treatment following a really stressful adverse event in which you were involved with a patient and the associated notes kept by your clinician. Many would assume that these records are categorically protected from lawyers. And sometimes that is true. However, during discovery, a court could require disclosure of such information if it is deemed relevant to the claims or defenses in a medical malpractice case, if a physician's mental health is placed at issue in the events surrounding the alleged negligence. This depends absolutely upon the jurisdiction and the specifics of the case. But private and undiscoverable are not necessarily the same thing.
Okay, Dr. Answine, do you have anything to add?
Oh, I think the most important thing, if you've never gone through this as a defendant or an expert, is how long this process is. From the time that you get named in a lawsuit to the time that it's settled or completed is going to be years. I didn't say months. I didn't say weeks. It's going to be years. So if you need to seek care, If you need to talk to people, the other thing they say is don't talk to anybody. Well, talk to your wife. Talk to your family if you need to. Talk to an expert if you need to, because your mental health will be affected by this. I don't care how stoic, how strong you are, where you are in your career. This is an insanely stressful time, and it's not short. We are talking a chunk of your life, maybe 3 years, maybe even more. Be prepared for that. Take care of yourself, because you can't be a good doctor in the future or be a good family member if you haven't taken care of yourself. And realize you are a good doctor. Because somebody sued you because there was a bad outcome does not mean that you're a bad doctor. In fact, 99.99% of the time, you are a good doctor and you had just a bad outcome. Take care of yourself, dig in. It's going to be a long process.
That's right. And another piece of advice I would give for folks who have an interest in just diving a little bit deeper into what the medical malpractice litigation process really looks like, you are able to search legal databases for a type of malpractice event that has been litigated for which there is published case law. For instance, you may try searching something as simple as intubation, aspiration, malpractice. And it will never be a comprehensive list, but there will be a large series of cases. And if there are some with facts that are similar to events that you were wondering about, you can click on the case. Of course, it's a little bit easier said than done, I suppose, without any formal legal education background, but you can click on the case and you can scan just to see exactly how are the facts presented, what types of defenses are presented, and essentially how do people see this in a world outside of the world of medical jargon and sophisticated medical knowledge in which we live every day. This is the basis for a lot of my medical legal research, in which I'm always seeking and happy to involve more people as well.
I want to add also that use the American Society of Anesthesiologists. Use your state Society of Anesthesiology. There are committees within the American Society of Anesthesiologists. There are thousands of anesthesiologists that are there to carry on these discussions and that could provide you with some personal insight. But your national, your state organizations are very good resources, not only to help you learn how to practice great anesthesia and to intubate people, but they're also there to discuss issues that come up as an anesthesiologist. And that does include malpractice situations, depositions. So go to the American Society of Anesthesiologists, whoever that is, in any pathway you want to take, and go to your state society and do that. Ask them if there are any resources that you can hold on to, or are there individuals who seem to have knowledge in this particular area, such as Ashley, who is not only an anesthesiologist, but she's going to be a lawyer. So look at your societies. They could be very, very helpful as a resource.
This is exactly why I went to law school. I want to be able to say someday soon that I can serve as a resource and the support for my fellow physicians, especially anesthesiologists who would need it, to sit and be not only a sounding board, but someone who's entirely versed in the legal aspects of any claims you may be facing and able to support you. I am not yet an attorney. I cannot provide you said legal advice at this time. And what I would advise is when an adverse event occurs, if there are grand rounds and other associated QI proceedings related to it, participate in those, utilize those, engage in those to the fullest of your ability. because those are proceedings that, again, we very rarely speak in any absolutes in law, but those are things that are generally protected from discovery and offer, if you will, safe places in which you can debrief about what happened, what providers may have wished they'd done differently. And you're now in a space where you are connecting interpersonally with other people who shared in the traumatic events that you experienced with the adverse event. And also, as Joe and I both emphasized, knowing that you absolutely need to take care of yourself, seek the appropriate mental health resources that you may need. I simply wanted to express that we can't take for granted that anything said or any interactions had with mental health providers for treatment automatically are not discoverable, just as a piece of information that many people are not aware of. However, extremely important to take care of yourself through these times. And as I mentioned, always interesting if there's a specific area of your practice about which you're curious and what types of actions may have followed from a medical malpractice standpoint based upon occurrences in that area, to engage in research as a partnership or independently regarding the case law that's available in that area, just to see how things really do play out in the real legal world.
And if you have nowhere to turn, this is the most important advice I can give you at the end. Go to your family pet, whether it's your dog or your cat or whatever it is, because they will listen unconditionally. They will love you unconditionally. And any bad day you have, they're going to make it brighter.
My cat is looking at me right now as you said that, Joe. Thank you for that.
Well, thank you both very much. This has been such an insightful conversation. This is incredibly valuable, and I hope a lot of individuals give this a listen. But thank you both for joining us today.
Thank you very much for having us.
My pleasure.
Well, and for our listeners of Central Line, thank you so much for tuning into this episode. Please ensure that you tune in again next time. And I just want to remind everyone that this is not legal advice. And join us again next time. Take care.
Protect your life and your practice with ASA's member-exclusive insurance program, covering everything from medical malpractice and health insurance to life, disability, dental, vision, travel, and even pets. ASA Insurance gives you peace of mind for every part of your life. Learn more and explore your coverage options today. asainsurance.com. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.